Good afternoon, student. Today we will discuss the topic that is regional traumatology. Regional traumatology consists of the many topics, that is injury around the shoulder, injuries around the arm, injuries around the elbow, injuries of the forearm, then injuries to the wrist, hand injury, dislocation and fracture dislocation of the hip joint, fracture of the femur, that is a very important topic, then injuries of the knees, fracture of the tibia and fibula, injuries to the ankle, injuries of the foot, pelvic injury, ribs, coccyx injury, injury of the spine, and peripheral nerve injuries. So these are the many topics included in the regional traumatology. So injuries around the shoulder. We all know shoulder is a very important joint of a human being. So firstly, in that there is a introduction, then fracture of the clavicle, injuries to the acromioclavicular joint, injuries of sternoclavicular joint, then proximal humeral fracture, dislocation of the shoulder. Dislocation of shoulder is also very important topic for theory and for oral and as well as in the clinical point of view. In that there is a anterior dislocation of shoulder, recurrent anterior dislocation of the shoulder and the fracture of the scapula. So the first point in that is firstly we see introduction in that the shoulder joint is a complex joint. So it consists of the glenohumeral joint, the acromioclavicular joint and the sternoclavicular joint. That is, in the shoulder joint, there is a acromion, glomerular cavity, head of the humerus, and sternum with clavicle is involved. Injury concerning all the three joints and the fractures involving the clavicle, scapula, and proximal humerus are discussed here. So fracture clavicle, this term clavicle is derived from the Latin root that is clavis, meaning key. Clavicle is S-shaped and is linked to the music symbol that is clavicular. Hence the name, the clavicle. The clavicle is the first bone to ossify in the body. It ossifies from the two primary centers. It is the only long bone in the body which is lying horizontal. Clavicle is the only long bone ossifying from a membrane and it is the only link between appendicular and axial scale. So it is the most common bone to be fractured in the children. Remember, In the children fracture, clavicle is a commonly fracture. It is very invariably end up maluniting after the fracture. So, this is a diagram of the clavicle which contains the lateral end, medial end, posterior border and anterior border with the shaft. So, this is the bony anatomy of the clavicle. Then, the functions of the clavicle are: clavicle increases the arm strength mechanism. It protects the neurovascular bundle consisting of subclavian vessel and brachial plexus. It gives attachment to important muscles around the shoulder. It braces the shoulder back during the rest and the motion. That is strut function. Mechanism of injury shows that there is a direct trauma. In this diagram, we can see a direct trauma over the clavicle, that is due to the fall on the point of the shoulder. This is common mode of the injury accounting for 91% of the cases. So direct trauma over the clavicle due to RTA, direct injury, and account for 8% of cases. For example, recklessness like this can break your clavicle directly by the injury. Indirect fall on the outstretched hand account for 1% of the cases. So, in this diagram, you can see the direct trauma to the clavicle. Then the sites of the fracture. So, 85% of the fracture clavicle occur at the junction of the middle and outer third. The diagram showing the various displacing forces in the fracture of the clavicle. One percent at the medial end of the clavicle, that is 5%. Lateral end fracture is uncommon, about 10%, and distal is 1/3. So classification of fracture clavicle by the Allman is group 1 fracture involving the middle 1/3 of the shaft. Group 2 fracture involving the lateral third distal to the attachment of the coracoclavicular ligament, and this is further subdivided into the two groups, which is proposed by Neal. So in that, type A, that is coracoclavicular ligament, is intact. In type B, when there is a coracoclavicular ligament is rupture. Type C are medial third fractures. So in this diagram, we can see a various displacing forces in the fracture clavicle. So this is a turnomastoid muscle. This one is pectoralis major, and this is a weight arm of the weight of the arm and gravity. So when there is a fracture of the clavicle, due to the gravity is displaced to downward. Then the clinical features, that is, the patient shows the signs and symptoms are pain. Firstly, there is a severe pain, swelling, deformity, and inability to raise the shoulder. So rarely the patient may present with pseudo-paralysis of the affected arm. Radiograph, that is this diagram of the X-ray showing that it is the routine AP view of the clavicle, that here the fracture is seen. The following view are recommended, that in the routine AP view, that is antero-posterior view of the clavicle. Lordotic view if the fracture is doubtful. Distal clavicle require a special radiography technique. Principle of treatment is that before proceeding to the treatment, proper one need to understand the two distracting forces acting on the fracture fragment in the clavicle, so making the treatment difficult. The sternomastoid muscle pulls up the medial end of the clavicle and pectoralis majors, and gravity acting through the arm pull down the lateral end. So in this diagram we can see how the fracture of clavicle when present, then there is how the sternocleidomastoid, pectoralis major, and the gravity changes the fracture. So sternocleidomastoid pull up, pectoralis major and gravity pull down at the lateral. So to counter the above two detrimental forces, that is opposite to one another, the shoulder should be braced up and back, and the arm should be supported while treating the fracture clavicle. Conservative method shows that this is the treatment of choice in the fracture clavicle and consists of the following methods. In these diagrams, there is a conservative treatment of the fracture clavicle is shown, that it is the collar and cuff sling, this is the strapping and sling suspension, and this is the figure 8 bandaging and collar sling for undisplaced fracture. Then the method of the internal fixation. Intramedullary fixation with the K-wire, rigid plate, and the screw fixation with AO semitubular or pelvic reconstruction plate. Diagram shows the radiograph showing the fracture clavicle plate fixation. So in that the indications are open fracture injury to neurovascular bundle, and if the fracture is threatening to penetrate the skin, there is a non-union fracture near the acromioclavicular joint, fracture to the shoulder, soft tissue interposition, and displaced epiphysis in the children. So complication of the fracture clavicle are, there is the neurovascular injury which may be immediate due to the direct force or delayed due to a very large callus, and the structure commonly injured are subclavian vessel and the medial cord of the brachial plexus through which the ulnar nerve is derived. This occurs in fracture of the middle one-third of the clavicle, which is most common. So, do you know ulnar nerve is the commonest nerve to be injured in fracture clavicle? Due to its compression between it and the first rib. So, malunion is a very common due to difficulty in holding the fracture fragments in position because of distracting forces which are already exposed, and it causes only a cosmetic problem and does not usually impair the functions. Hence, no treatment is required. So, problems are possessed by the malunion of the clavicle are there is a cosmetic problem which are mentioned in the above slide. Then orthopedic complaint that are frequent episode of the shoulder fatigue. Then sleep problem, that is the patient complains of inability to sleep on side. There is a difficulty to sleep on the side. Then neurological problems, that is features of thoracic outlet syndrome. Remedy is faced with these situations. The patient require corrective osteotomy and the rigid internal fixation with medullary pin or plate and the screw. Non-union is rare and require open reduction. So there is the internal fixation and bone grafting. Quick facts of the fracture of the clavicle are it is the most common fracture in the children as we see. The common mode of the injury is direct. Nearly all the fractures are treated which are close. There is the open reduction for specific indications. Malunion is rule but no functional disability. So, next is the injuries of the acromioclavicular joint. It is the joint between acromion and the clavicle. So, it is also called as the ACM. That is acromioclavicular joint is diarthrodial joint with fibrocartilaginous disc between the two bones that is similar to the meniscus. The acromioclavicular joint is essentially a plain joint. It permits a gliding rotation between the clavicle and the scapula. So, its structural integrity depends on the intrinsic capsular element and the superior acromioclavicular ligament and the extrinsic coracoclavicular ligament. which forms a hood over the interval between the coracoid process and the acromion. So, there is a coracoclavicular joint in which coracoclavicular ligament form a hood over the interval between coracoid process and the acromion. So incidence is 12% and is common in young, that is in male to female ratio is 5 is to 1. So it is mostly common in the young male also. So the common name of acromioclavicular injury is shoulder separation. Acromioclavicular injuries are 4 to 5 times more common than sternoclavicular injury. So, next is the mechanism of the injury. Here, the direct force is most common mechanism. That is, when we see this diagram, so diagram showing the most common mechanism of the injuries of acromioclavicular joint of injury as in RTA, that is road traffic accident, assault, or in athletes event like trekking, etc. Their indirect force is due to the fall on outstretched hand. Extremity is relatively rare. Clinical picture shows that the patient complains of pain, swelling, and difficulty in raising the arm up. The patient supports the affected shoulder by holding elbow with unaffected hand. On examination, there is tenderness and lateral end of the clavicle is predominantly felt. So, in this second diagram, there is a ACM joint injury, that is acromioclavicular joint injury with the clinical appearance. So, in this we can see how there is a tenderness and the lateral end of the clavicle is prominently felt. So, this is the ACM joint injury. Then next is a classification of the ACM injuries based on the injury to the acromioclavicular and coracoclavicular ligament. Diagram shows the acromioclavicular joint injury shows a ruptured acromioclavicular ligament, that is ACL, and ruptured coracoclavicular ligament, that is CCL. In type 1, there is a minor sprain to acromioclavicular ligament. That this is a ruptured acromioclavicular ligament ACL, and second that this word that shows the ruptured coracoclavicular ligament. So the type 1, that is minor sprain to acromioclavicular ligament, and type 2 shows the rupture of the ACL and the sprain of the CCL, that is coracoclavicular ligament. Both in type 3, both ACL and CCL are ruptured and clavicle is displaced upward. In type 4, same as the type 3, but with the upward and posterior displacement of the clavicle. In type 5, Type 3 with severe displacement of the clavicle toward the base of the neck. And in type 6, there is a inferior dislocation with the clavicle toward the base of the neck. So, this is the acromion. This one is rupture acromioclavicular joint. This is a rupture coracoclavicular joint. This is a clavicle. This is a sternum, and this one is a scapula. So this is the classification by the Sachs and the Salvatores. Then the radiogram, that is X-ray. So what we see in the X-ray, that the following views are required to see this injury. That is AP view, anteroposterior view with 50-degree cephalic tilt to prevent overlap of the spine of the scapula on routine AP view. And diagram, that radiograph showing ACM joint dislocation, and lateral view, that is axillary view of the shoulder. So in this there is a stress radiograph to differentiate from type 2 and type 3 by suspending a weight of 10 to 15 lbs around the wrist. So this is a X-ray which shows ACM joint dislocation. In the management for this, there is a rest ice bag used, then NSAID, that is non-steroidal anti-inflammatory drug, etc. are useful with sling for 10 to 14 days, which are adhesive striping, elastic wrapping, cast or harness. Surgery is required for persisting pain. 3. That is conservative method like reduction and retention with the sling and harness. The surgical method include for these are acromioclavicular repair, coracoclavicular repair, excision of distal end of clavicle for symptomatic cases, then dynamic muscle transfer by transferring the coracoid process. Type 4, 5, 6 require open reduction, internal fixation, repair and reconstruction. In complication associated with the fracture of the clavicle are coracoclavicular ossification, osteolysis of distal clavicle, complication after surgery like infection, etc. Then complication after non-operative treatment like joint stiffness, periarthritis, etc. Delayed complications, these include a step like deformity, ACM joint, that is arthritis in that pain during weightlifting, injury of sternoclavicular joint. So next is the injury to the sternoclavicular joint. In this diagram, we can see the most common mechanism of injury of sternoclavicular joint. So firstly, sternoclavicular joint, it is a saddle joint. It represents the only bone-to-bone connection of the upper limb to the trunk and to absorb the shock transmitted from the arm to the shoulder. And it has a fibrocartilaginous disc between clavicle and the mandible. So it derives its structural strength from interclavicular ligament. The intra-articular disc ligament and the capsular ligament strengthen it largely. Mechanism of injury, that this is the least commonly dislocated joint because of the strong ligament. So here the direct force cause these injuries. For example, when there is a collision of an athlete with another person or a post, etc., indirect force is the most common mode of the injury. For example, loading the upper shoulder while someone lies on the side. So, in the diagram, we can see that the most common mechanism of the injury of the sternoclavicular joint and incidence is about 3% and more common in the young male. So, in the young male, injury to the sternoclavicular joint is most common. So, in this diagram, we can see here that there is a fracture of the or injury to the sternoclavicular joint. Then the causes are the road traffic accident, that is RTA, is responsible for 80% of cases. Sports related injuries account for remaining 20%, and the classification of diagram shows that sternoclavicular joint injuries, when in diagram A you can see that here is the partial separation of sternum and the clavicular joint, and here is the total separation of the sternal clavicular joint. So this is a diagram of partial separation and this is total separation. Anatomical classification shows that anterior dislocation are more common. And second is the posterior dislocation. Etiological classification shows that there is a traumatic, that is firstly the sprain, then acute dislocation, then recurrent dislocation, unreduced dislocation, and in automatic there is a voluntary or traumatic in that voluntary, involuntary, congenital, degenerative, and infective etiology. Then clinical features shows that the patient complained of pain and swelling. Medial end of the clavicle is of both the clavicle. There is a pain and swelling. Medial end of the clavicle is prominent in anterior dislocation and affected shoulder is the short. So there is a lateral compression test is positive. Then radiograph, that is AP view, shows that is often difficult to interpret, especially 90% cephalocaudal view. This helps to see the medial end of both the clavicle, that is serendipity view. Then tomograms are useful. CT scan and MRI are help to study the position of the clavicle with respect to the sternum and soft tissue respectively. So in the management, there is the mild sprain. The treatment consists of ice, sling, painkillers, etc. and subluxation. The treatment method are ice, that is in first 12 hours, warm in 24 to 48 hours, clavicle straps, the ligature, the figure of 8 and excision of medial end